Okay. A 72-year-old man comes to the physician because of 2 month history of difficulty walking and burning and tingling sensation in both hands. He has hypertension treated with hydrochlorothiazide. He takes no other medication. Vital signs are within normal limit. Cranial nerve function is intact. There is atrophy of the intrinsic muscles of the both hands, and grip strength is 4 by 5. Muscle strength in the lower extremity is 4 by 5, distally 5 by 5 proximally. Muscle tone is increased. Deep tendon reflex are 1 plus in the upper extremity. Deep tendon reflex 1 plus in the upper extremity and 4 plus um, in the lower extremity. Which of Babinski sign is present bilaterally. Sensation to pinprick and temperature is decreased over both hands. Sensation to vibration is decreased over all extremities. Which of the following is the most likely diagnosis? Sense, no,
Ready?
yes.
So it's cervical stenosis. This patient presents with motor and sensory symptoms concordant with the distribution of the C8 dermatom hematom. C8 nerve contributes a large portion of to the ulnar nerve, which primarily arises from CAT1 nerve root of the brachial plexus. The ulnar nerve supplies motor fibers to the intrinsic muscles of the hand and sensation of it anteromedial ring and small fingers and medial palm. Damage to the roots of or the nerve along its course at the cubic of donor can result in motor dysfunction of the fingers and numbness or paresthesia involving the medial aspect of the upper extremity. Injury occurring at C8 root often occurs from cervical stenosis, foraminal impingement from disc osteophyte complex, trauma, malignancy, spinal epidural, spinal hematoma. Mm. It's not B, what is B? ALS or motor neuron disease. Oh, that's what it's called. Progressive neurodegenerative disorder that affects the anterior horns along with the lateral corticospinal tract as it descends in the brain and spinal cord. Subsequently, patients demonstrate a combination of upper and lower motor neuron findings in an asymmetric distribution that may include the bulbar muscles. Sensory impairment will be atypical and a pattern of dysfunction can be localized to a specific dermatome level is more suggestive of cervical stenosis. Okay.
So as it is C8 and T1 are root compression like due to cervical stenosis. That's why there is upper motor neuron feature, lower motor neuron feature along with the sensory problem.
That's not how I
Okay, how you picked.
cervical stenosis. Remember, I told you is upper motor neuron in the lower limbs and lower motor neuron problems in the upper limbs.
Yes,
Mm.
and there is sensory is involved. Dorsal
Um,
column is involved. Pinprick is involved.
um, I don't know if in all the questions, but yeah, I guess I feel like there are some questions where I didn't see the sensory thing. But yeah, I guess you can, yeah, just put, yeah, sensory is involved.
Sensory thing is actually complicating this answer.
Yeah, yeah.
Okay, next. A 38 year a 38-year-old woman comes to the a 38-year-old woman comes to the clinic with her husband because she has had 6 episodes of severe abdominal pain during the past 4 months. 6 episodes of severe abdominal pain during the past 4 months. She says she says when the episodes occur, the pain is continuous and located all over my belly. During initial episodes, the pain persisted for 3 to 4 hours. But during more recent episode, the pain has lasted 2 to 3 days. The rates of the pain at its worst as an 8 on a 10-point scale. The episodes are accompanied by nausea, bloating, numbness in her hands and the feet, and severe burning pain in her thighs and the calf, and severe constipation. These associated symptoms subside the resolution of the abdominal pain. She also passed red urine about her most recent episode. Her husband says she often sweats during these episodes, and he once measured her pulse 100 per minute. The patient has no history of serious illness, takes no medication. He has a family history of similar episodes of multiple relatives. Vital signs are within normal limit. Physical examination should no abnormality. Which of the following is the most likely responsible for the color of this patient's urine?
Ready?
1 minute. Okay.
So it's called fibrinogen deaminase. Acute intermittent porphyria is most likely diagnosis in this patient with episodic abdominal pain and peripheral neuropathy in stocking and globin distribution, which is caused by autosomal dominant mutation in the porphyrin deaminase gene HMBS. This enzyme catalyzes the third step in heme synthesis, which combines PBJ molecules into hydroxyapatite, which is subsequently converted to uroporphyrin 3. Loss of this enzyme leads to accumulation of PBJ, which is toxic to the nervous system. Additionally, increased activity of the upstream enzyme DALA leads to accumulation of ALA, which is also toxic. PBJ accumulation in urine produces a tinge, reddish tinge, and is also diagnostic when detected by urine. The mutation affects both red cells and hepatocyte. The disease manifestations are primarily neurologic and include peripheral nerve neuropathy, bladder dysfunction, autonomic dysfunction. Abdominal pain is classic and results from often results from illness. The penetrance is low, so a family history is not often present, which can delay diagnosis. Disease flare can occur after exposure to certain triggers such as medications, tobacco, alcohol, stress, and starvation. Carotene is a naturally occurring pigment um, that is converted to vitamin E. A. It's found in many plants such as carrots, pumpkin, sweet potatoes, and in many vitamin supplements. It may cause a harmless orange urinary discoloration. When consumed in excess, person does not produce neurologic and GI symptoms. Hemoglobin may may impart a reddish discoloration to the urine associated with variety of autoimmune infectious inflammatory coagulation. Blah, blah. However, this patient presentation is more severe. Okay, next.
Okay. A previously healthy 24-year-old man. A previously healthy 24-year-old man is brought to the physician because of 3-day history of progressive loss of vision in the right eye and pain behind the eye movement. 3-day history of progressive loss of vision in the right eye and pain behind the eye movement. He has no history of similar symptoms. Fundus examination shows no abnormality. Visual acuity 20 by 100 on the right. Visual field testing show right central scotoma. There is right afferent pupillary defect. Over the next 10 years, the patient is greatest risk of which of the following?
Ready?
Yes.
Is multiple sclerosis. Optic neuritis results from autoimmune demyelinating inflammation of the optic nerve in young, often female patients with unilateral vision loss and pain that is exacerbated with extraocular movement. Ocular examination discloses decreased visual acuity and color vision. Mm, a relative afferent pupillary defect, possible optic disc edema. Diagnosis is confirmed with fluid attenuated inversion recovery. MRI sequences showing hypertensity of the optic nerve. But patients with optic neuritis are at increased risk for multiple sclerosis, and optic neuritis is a common initial finding um, in patients with MS. Recently, autoantibodies against myelin oligodendrocytes glycoprotein and aquaporin 4 have has been identified as causative of some causes of optic neuritis. Patients who develop optic neuritis due to antibodies against the MOG and the aquaporin 4 often have severe presentation but also decreased risk of subsequent MS compared with patients with optic neuritis who lack these autoantibodies. The optic neuritis treatment trial demonstrated that short course of treatment with high dose IV methylprednisolone speeds up rate of recovery and delays onset of MS, although it does not impact visual acuity. It also demonstrated that the presence of quantity of periventricular white matter lesions on MRI is the most important prognostic risk factor for the subsequent development of MS. It's not the macular degeneration may present with insidious blurring of central vision and metamorphosis. Advanced age is the biggest risk factor associated with developing macular degeneration. Okay, next.
Okay, next. A 56-year-old man is brought to the emergency department by ambulance 1 hour after he was found by his neighbor sitting in the hallway of his office apartment building and speaking unintelligibly. On admission, the patient is confused and somnolent. He is unable to provide medical history. He has alcohol-related cirrhosis complicated by bleeding from esophageal varices, hypokalemia, metabolic acid, metabolic alkalosis. His medications are spironolactone, furosemide, nadolol, ursodiol. Mm, during his last clinic visit 2 weeks ago, during his last clinic visit 2 weeks ago, the patient started that he has remained abstinent from alcohol. He has abstinent from alcohol use. His examination at the time showed mild confusion. Today the patient appears somnolent, but he is likely aroused. He is 175 centimeter tall, weight is 56 kg, BMI 18, temperature 98.2, pulse 78 per minute, respiration 60 per minute, blood pressure 114 by 72. Physical examination show primary erythema and gynecomastia. The abdomen is protuberant with the caput medusa radiating from the umbilicus. When he asked to outstretch his hand with the wrist extended, the patient's hand transiently drops in a non-rhythmic manner. Mental status examination show a reduced attention span. He is oriented to person but not to place, time, situation. Lab show hemoglobin 11.8, hematocrit 34, leukocytes 7,800, sodium 133, potassium 3.2, blood urine nitrogen 14, creatinine 1.2, and ammonia 50%. Which of the following is most appropriate pharmacotherapy at this time?
Ready?
Yes.
So it's rifampicin. Hepatic encephalopathy is commonly associated with decompensated liver cirrhosis. Signs of hepatic encephalopathy include confusion, stupor, hysterisis, tremor, and myoclonus. Physical. Hepatic encephalopathy results from accumulation of ammonia produced by colony bacteria. Serum ammonia concentration in patients with hepatic may be increased, though this is not necessary diagnosis. Treatment for hepatic encephalopathy include rifampicin and lactulose. Um, Famixin is a gut-selective, non-absorbable antibiotic with activity against gram-positive and gram-negative bacteria. It acts on the beta subunit of DNA-dependent RNA polymerase to inhibit bacteria synthesis is bactericidal. Lactulose is degraded by colony bacteria to create an acidic environment, thereby converting ammonia to ammonium, which cannot be readily absorbed across the gut wall. Is then excreted with feces, lowering the total body level. Okay, next.
A 46-year-old a 46-year-old woman comes to the emergency department 18 hours after the sudden onset severe intermittent left-sided facial pain. Sudden onset severe intermittent left-sided facial pain. She describes the pain as an electric jolt that turned on and off every minute. The patient started the pain started while she was brushing her teeth uh, the previous evening and is localized to the left premolar area and upper dental arch. He reports that ibuprofen relieved the pain for 3 hours, but the pain is recurring this morning. She rinsed her mouth with cold water. She has hypertension, multiple sclerosis. Medications are metoprolol, lisinopril, fingolimod. Her maternal aunt has multiple sclerosis. The patients appear anxious occasionally. The patients appear anxious and occasionally winches in pain. Temperature is 98.4 Fahrenheit, pulse 64 per minute, uh, respiration 18 per minute, blood pressure 146 by 88. Examination shows no abnormal. Which of the following reflexes should be tested in order to determine if further diagnostic studies are indicated at this time? Is it trigeminal neuralgia?
I think so. Yeah, I guess. Yeah.
Ready?
Yeah, it's corneal. Yeah. Trigeminal neuralgia, neuropathic pain disorder that presents with severe shooting and burning within the innervated region of the sensory branches of the trigeminal nerve. The trigeminal nerve divides into three sensory branches, V1 to V3, which innervate the forehead, V1, the skin overlying the zygomatic and maxillary bones, V2, the mandible, V3. The pathophysiology of the pain is believed to be related to compression of the trigeminal nerve by adjacent blood vessels or bone as it exits the skull base. Symptoms may be triggered by light touch, shaving, swallowing, or may occur without any precipitant. Pain is generally described as severe. The trigeminal nerve also mediates the corneal reflex, which involves blinking of the eyelids caused by stimulation of the cornea. Trigeminal neuralgia associated with loss of the corneal reflex. Treatment include carbamazepine or surgical decompression. It's not pupillary eye reflex, involves the optic nerve and oculomotor nerve and causes constriction of the pupils in response to light. Loss of pupillary eye reflex can occur in the setting of optic nerve injury, brainstem oculomotor nerve injury. Okay, next.
A 33-year-old woman comes to the physician 24 hours after fainting episode. 24 hours after fainting episode. Mens has occurred at regular interval over the past 6 months. She has had numbing and tingling. He has a numbling and tingling of her left hand for 2 years. She has had intermittent episodes of uh, uh, mm, sharp stabbing lower abdominal pain over past 4 years. She has had no nausea, vomiting, diarrhea, constipation. Treatment is acetaminophen, ibuprofen, codeine has been ineffective. These exploratory laparoscopy did not disclose the cause of the pain, and surgical treatment for uterine adhesion did not provide any significant relief. Had she has a history of multiple sexual partners, but has abstained from the past 3 years because of dyspareunia. Patient's blood pressure is 140 by 84. The abdomen is moderately tender to light and deep palpation with no rebound tenderness. Bowel sounds are active. Pelvic examination is difficult to perform and increased cervical pain. Which of there is bilateral tenderness on palpation of the ovaries? Which of the following is most likely diagnosis?
Jesus.
Lots of things she
This
has.
stuff is, it has like so nothing, like nothing goes together. Sexual partners, dyspareunia. I mean, we'll go with endometriosis, but then endometriosis, what about the numbing and tingling of the hand? That got nothing to do with endometriosis. Crohn's, there is no diarrhea, nothing. Illness, anxiety disorder, I don't even know what the hell is that. That must be like behavioral stuff. Somatization, no. Only thing that's left is conversion disorder, but Jesus Christ. I guess. Maybe the only thing that.
Okay.
Ready?
Yes.
Oh my God. Somatization. This patient with numerous non-specific symptoms with no medical explanation after extensive workup has a presentation concerning for somatization disorder. In somatization disorder, somatic symptom disorder, the patient is excessively preoccupied with one or more somatic symptoms. I didn't say she was preoccupied anyway. Such that these symptoms disrupt the patient's daily life. These symptoms may or may not originate from an underlying disease, though they are typically unconscious. Um, Unconsciously produced or exacerbated by psychological factors such as stress. Patients persistently devote excessive time and energy to these symptoms or related health concerns, repeatedly going to the doctor. Patients often undergo extensive diagnostic testing that is unrevealing management of somatic symptom disorder centers around regular primary care follow-up that diagnostic skills provide the assurance and avoid unnecessary tests. Conversion disorder, also known as functional neurologic symptom disorder, involves neurologic symptoms such as sensory or motor dysfunction that are not fully explained by objective findings on physical exam or imaging. Functional neurologic symptom disorder is postulated to represent a subconscious conversion of intolerable emotional distress into physical symptom. Yeah, but still doesn't say why it's not that. Hmm, okay,
Okay. So
okay.
how somatization disorder, we will think that in here patient will do lots of workup, but there is no symptom.
What?
So
What do you mean? Uh-huh.
I want I want to differentiate between somatization and conversion.
You cannot. I don't think this is a good question because usually somatization disorder it will come with like the patient is really worried that she has something bad, she came for the stomach pain but then they didn't find anything, but she's still really worried that she has stomach cancer and things like that. And that's usually how somatization. So because here in this question they didn't even say that she's really worried about that, it has affected her life and all these things. I That's why I didn't go with that. Conversion disorder is usually like the patient will come like she just had a really stressful thing, like the parents divorce or got a really bad accident or something, and then she started having like blind episodes where she don't see anything. But then you check fundoscopic, everything is fine. You check the optic nerve, everything is fine, whatever. So usually that's how the conversion. But this is not like a really good uh, explanation. I'm thinking they're trying to say that because she had 3 laparoscopies, so that means that she went to the office to the doctor a lot of times. That means that she's worried about her symptoms. I think that's how they're trying to correlate that with somatization, like she's worried about. But I don't know. I don't think this is a good question, like
Okay.
usual question that you see with somatization.
Okay. Okay, can you give me a 57-year-old man comes to the physician because of 6-month history of progressive hearing loss in in the left ear. He initially only had difficulty hearing while taking on telephone, but now he has difficulty hearing most of the time. During this period, he occasionally has had a 30 seconds episode of unsteadiness and spinning sensation. He has been otherwise healthy. Examinations show flattening of the Examinations show flattening of the left nasolabial fold and decreased wrinkling of the forehead on the left side. There is rotatory nystagmus on the right lateral gauge and profound sensory neural hearing loss. Mental status shows no abnormality. Which of the following is most likely lesion of this patient?
Hmm. 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 Ready?
Yes.
What is it right here? Is cerebellopontine angle acoustic neuromas are tumor derived from Schwann cells involving the vestibulocochlear nerve. Okay, the vestibulocochlear nerve originates between the pons and the medulla oblongata and exits the brainstem near the cerebellopontine angle. Symptoms associated with the development of acoustic neuroma include hearing loss and tinnitus, associated with cochlear nerve as well as gait instability, and vertigo associated with the vestibular nerve. As tumors enlarge, there may be involvement of the trigeminal nerve or facial nerve. So 5, 7, and 8, and 7 and 8. Patients with neurofibromatosis type 2 may present with bilateral acoustic neuromas. Imaging studies include CT scan or MRI can be used to make the diagnosis. Treatment option include surgical resection and radiation therapy. It's not brainstem tegmentum as the is the portion of the brainstem ventral to the cerebral aqueduct and foreventricle. This area will not be affected by the acoustic neuroma. Its not temporal lobe contributes to the cerebral cortex and is associated with auditory perception, language recognition, comprehension, and speech. Lesion involving the Wernicke area of temporal lobe results in Wernicke aphasia, where patient can produce speech though it's not garbled or and is inappropriate. What is garbled is inappropriate. Sorry. Okay. Next.
Next. Oh, an 82-year-old woman is brought to the physician because of 3-month history of brief memory loss, 2 to 3 weeks weekly, 2 to 3 times weekly. She also has no she also has difficulty maintaining balance. She has glaucoma, hyperlipidemia, hypertension. She has glaucoma, hyperlipidemia, hypertension. Her medication of pilocarpine or drop. Her medications are pilocarpine, yeah, drop-losertan, atorvastatin. Her pulse is 92 per minute, respiration 16 per minute, blood pressure 132 by 84. Examination show arcus senilis, and slight restriction of the outward gaze. Deep tendon reflex are decreased at the ankles compared with the knee. On gait testing, she walks flexed at the wrist and unable to tandem walk. On mental status examination, she is fully oriented. She performs serial 7 without difficulty. Her immediate recent memory loss in her immediate recent and remote memory is intact. She displays no normal abstract thinking. Which of the following best explains this patient's finding?
Ready?
Mm, okay.
Okay. So it is psychomotor slowing. This patient with brief episodic memory loss, arcus senilis, I don't know what is that, decreased Achilles reflex and Flex posture is showing signs of psychomotor slowing consistent with normal aging. Normal aging includes a slow decline in executive function in attention span and problem solving after age 70. Other findings consistent with aging include decrease or absent Achilles reflex. Arcus senilis, gray or white arch visible around the outer edge of the cornea. Hmm. Decreased vision and hearing, decreased immune response, and increased suicide rate. Despite these common changes, an individual experiencing normal aging should still be able to function in society. Cerebellar degeneration may present with truncal and limb ataxia, broad-based gait, and intention tremor. Multiple lacunar lymphi may present with purely motor symptoms, purely sensory symptoms, ataxic hemiparesis, and dysarthria or dysarthria. Infarcts in these deep dilating vessels are secondary to hypertension, diabetes, and hypertonic cholesterolemia. Okay, let's Google the arcosenitis. What's this?
Which one? The
This
white
the
ring. Okay.
I'm guessing, yeah, it's normal. Okay, next.
A previously healthy 37-year-old woman is admitted to the hospital because of 3 day history of weakness of her arms and the legs. Weakness of her arms and the legs. Her symptoms began 6 days ago with backache and pricking sensation in her legs. She is alert and oriented. Vital signs are within normal limit. Cranial nerves are intact. Muscle strength is 3 by 5 in the distal upper and the lower extremity and 4 by 5 in the proximal upper and the lower extremity. She is unable to walk without assistance. Sensation to pinprick is decreased below the knee. Deep tendon reflex are absent. Patellar tendon reflex are bilaterally. Deep tendon reflex are absent in the Achilles patellar tendon. Bilaterally, Vavency sign is absent. Bilaterally, glucose 102 in on CSF, glucose 66, 90, and WBC considered. Which of the following is the most likely diagnosis?
This is 66.
Um,
CSF, CSF,
back
protein
mm,
is
sensory crystal crystal
distal.
mm,
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 mm, mm, mm, mm, mm, mm,
no.
mm. Ready?
Okay.
Okay, so it is Guillain-Barré. This patient, I think the key here was the CSF. The patient most likely has GBS leading to ascending polyneuropathy.
Protein
And
is
GBS
slightly high.
is super high. Normal is less than 40,
Okay.
and then glucose is normal. In GBS, a preceding infection, like Campylobacter jejuni influenza, leads to autoimmune cross reactivity with the myelin of the nerve roots existing in the spinal cord. The ventral nerve roots containing motor and sympathetic efferent are most commonly involved, though the dorsal nerve roots controlling sensation may also be affected, as such patients typically present with acute symmetric muscle weakness with depressed or absent deep tendon reflexes, reflecting lower motor neuron pattern dysfunction. That begins in the lower extremity and may rapidly ascend to even the upper extremity bulbar respiratory muscles. Autonomic dysfunctions like BP, cardiac is common. Sensory deficits and pain can also occur, although these symptoms are typically mild compared with motor dysfunction. The diagnosis is confirmed with increased CSF protein with normal cell count and lumbar puncture. Term albuminocytologic dissociation, though they reflect generalized inflammation. Thought to reflect generalized inflammation. Okay. Management include respiratory support and for severe cases, plasma exchange and or IV immunoglobulin therapy. IV immunoglobulin may also work by neutralizing the cross-reactive antibodies that cause GPS. And you can also delete the other one, like cervical spinal. There will be upper motor neuron, so
Mm,
that's no. Multiple sclerosis, is upper motor, so that's no. Myasthenia gravis, they're gonna give you the whole. Once they keep going, it's better in the it's worse in the afternoon, blah blah blah. So it's not that. And syringomyelia, I think it's only in the upper limbs, so it's not. So you can delete all the other ones. You'll be left with that. Okay,
okay.
next.
A 57-year-old man is brought to the emergency department 1 hour after his wife was unable to arouse him from sleep. He had hypertension but is currently taking no medication. His blood pressure is 190/100. Examination shows both eyes deviated on the left. He does not withdraw his right upper and the lower extremity to painful stimuli. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Yes.
So a CT scan of the head. This is pretty okay. This patient with uncontrolled hypertension, left eye deviation, right side weakness, and depressed mental status has a presentation concerning with intracerebral hemorrhage. ICH can occur in patients with chronic hypertension, typically due to hemorrhage from small penetrating arteries of the pons, midbrain, thalamus, putamen, whatever. Risk factors for hypertensive ICH include uncontrolled hypertension, antiplatelet or anticoagulation therapy, such as aspirin and warfarin. Patient can present with headache, vomiting, confusion, altered mental status, coma. Focal neurologic deficit depend on the site of ICH and can include hemiparesis, hemisensory symptoms, gaze, palsy, dysarthria, aphasia, or if the cerebellar ataxia, vomiting, and disequilibrium. A patient may manifest upper motor neuron examination findings such as spasticity, hyperreflexia, blah, blah. Diagnosis is made with non-contrast CT scan of the head, which would show hyperdense interparenchymal acute blood products. I think the key here is once somebody comes with signs of stroke, the first thing you do is CT scan, always. I think that's the key here. Okay, next.
So if like any patient with hypertensive, this is urgency, isn't it? BP 180/100. So hypertensive urgency along with the eye features. So we will do CT scan to rule out any neurological problem.
No, it's like if somebody comes with signs of stroke, doesn't matter, it don't have to be hypertensive. If somebody comes with signs of stroke, the first thing you do is CT scan. It's just easier and faster. So that's the first thing you do to rule out ischemic stroke. So now once you rule out ischemic stroke, in its non-contrast, because you don't want to add contrast
Yes,
on
yes.
that. Yeah, that's just the general rule for all. Yeah. Once you roll out the ischemic stroke, then you can go into whatever whatever you want. It's just yeah.
Okay.
Mhm.
A 72-year-old man comes to the physician because of 3 month history of dizziness, 3 month history of dizziness on standing. He has angina pectoris. He has angina pectoris. Mm, esophageal reflux and degenerative joint disease and type 2 diabetes mellitus. Medications include cimetidine, aspirin, gemfibrozil, isosorbide dinitrate, and metformin. His pulse is 80 per minute, blood pressure 150 by 90 millimeter of mercury, while supine. His pulse is 68 per minute, blood pressure is 118 by 70 millimeter of mercury. Standing. The remainder of the examination show no abnormality. His hematocrit is 42%. Discontinuation of each of the following medication is most likely to resolve his orthostasis. Mm,
Ogawa was cimetidine. What is cimetidine again?
Cimetidine is H2 blocker.
Which
Ranitidine, famotidine.
oh, I probably not that. Okay, ready?
Yes.
Okay. So it's absorbed nitrate. These patients' symptoms of positionally dependent dizziness, unsteady are consistent with orthostatic hypotension. Orthostatic hypotension is defined as sustained decrease in systolic SBP greater than 20 or DBP greater than 10 within 3 minutes of standing. The underlying cause is dysregulation of the sympathetic and parasympathetic autonomous nervous system, resulting in reduced capacity to increase vascular resistance or cardiac output on standing, such that standing results in hypotension and decreased cerebral perfusion. However, orthostatic hypotension may also be caused by or exacerbated by meds, including antiadrenergic such as beta or alpha 1 blockers, beta blockers, alpha 1 blockers. Narcotics, antihypertensives such as isosorbide and protein vasodilator used to treat angina pectoris. Patients typically experience presyncope, syncope, and lightheadedness that is intermittent and positional. The diagnosis is confirmed with TIL testing. The patient heart rate, BP, and symptoms are observed as the table is rotated from supine to upright. Oh, that's what it is. Okay. Patients typically report symptoms with changes in position. Until treatment involves correction of reversible cause such as dehydration and discontinuation of the meds when possible. Next.
Okay. A 63-year-old man is brought to the emergency department because of 3 hour history of double vision. She also has 1 week history of moderate pain and numbness around her right eye. She has no history of serious illness. Taking medication examination shows exophthalmos of the right eye. When he asked to look on the right, the patient reports double vision. The right eye does not fully abduct. Sensation to brain pig is decreased in the right forehead and below the right eye. Which of the following is the most likely diagnosis? Oh, the right forehead.
Hmm. The fuck? The pain and numbness on the right eye. Mm.
If
Ophthalmos.
we
Oh.
if we follow abduction, then
Hmm.
PPRF can be one of the answers.
If you follow abduction. But why would that be pain? Doesn't make sense. And why would that be exophthalmos?
Subthalamus. That's true.
Mm, maybe, but I don't know. Maybe yes, I don't know. But just ready.
Yes.
Okay.
CVS.
Yeah, it makes sense. Cavernous sinus lesion. Venous sinus thrombosis classically follows an infection or injury involving a structure with infection of injury involving a structure then by the cavernous sinus and results in cranial nerve deficits involving those that traverse cranial nerve deficit involving those that traverse the cavernous sinus, like 3, 4, B1, B2, 6. 3, 4, B1, B2, and 6. Causes include sinusitis, orbital cellulitis, dental infection, pharyngitis, and cellulitis or abscess, especially within the danger triangle of the face formed by the apex of the nose and the corners of the mouth. Hmm. Features include fever. Features include fever, orbit pain, exophthalmos, periorbital edema, um, impaired pupil reactivity, and impaired extraocular movement, causing diplopia. Impaired corneal reflex and sensation in the V1, V2 distribution can also occur. Okay. When the cause is orbital cellulitis, patients may additionally present with palm with extraocular movement, with pain with extraocular movement and optic nerve dysfunction, which can be suggested by the presence of decreased color perception. Relative afferent pupillary defect and optic disc edema. Patients in whom cavernous sinus thrombosis is suspected should undergo urgent CT venography or CT MR venography, contrast enhanced MR venography, sorry. Treatment involves anticoagulation, BP, broad spectrum antibiotics, and antifungals. Even with prompt recognition and appropriate treatment, the burden of long-term complications, include visual impairment and stroke, remains high. And there's not, how were you? Posterior communicating artery aneurysm may compress the ipsilateral oculomotor nerve, resulting in toxic extra, hypotrophia, I don't know, diplopia and mitiasis. The detection of a new oculomotor nerve palsy is a medical emergency, and as aneurysm can lead to life-threatening subarachnoid hemorrhage. Okay, next.
Next. A previously healthy 3-month-old boy is brought to the physician because of 3-day history of decreased feeding. Because of 3-day history of decreased feeding, he also has a 1-day history of cough, and a 1-day history of cough worsens when attempts to feed. His mother reports his mother reports that he seems hungry but tires out while feeding. He was born at 40 weeks of gestation, 25-year-old primary gravid woman following an uncomplicated pregnancy and delivery. Birth weight is 3.6 kg until 1 week ago. The patient is alert, quiet, and a weak cry. She is uh, 50 percentile length and weight. Temperature is normal, blood pressure normal, respiration normal, and sorry, blood pressure is 72 by 40. Examination of the skin shows no abnormality. Facial expression is absent. They are the pupils is 5 mm and sluggishly reactive. The gag reflex is decreased, transmitted to the upper airway. Noises are heard. No murmur are noted. Abdominal examination shows no abnormality, which pulse is 2 plus and symmetric. There is head lag and no spinal. There is head lag and no spontaneous movement of the extremity. Muscle tone is decreased. Deep tendon reflex are normal. Which of the following is most likely to confirm the diagnosis?
Ready.
So,
Mm,
ready?
no. How are you able to find it so quick? Let me see. Soil. I guess the soil thing is no lag. There is head lag and no spontaneous. Blah. Muscle tone is decreased. Mm, tires out while she's feeding. Is it this one? I guess I'll go. Yes, ready. So it is stool toxin acid. This patient with difficulty feeding, hypotonia, facial muscle weakness, has a presentation consistent with infantile botulism. Botulism is an acute disease of the neuromuscular junction caused by exposure to Clostridium botulinum toxis. Botulinum is a gram-positive spore-forming obligate anaerobe bacterium produces botulinum toxin, a potent neurotoxin that is absorbed into the N-terminal of cholinergic motor neuron where it cleaves the nerve proteins, thereby preventing the release of acetylcholine vesicles into the neuro. Yeah. Botulism is often encountered as a foodborne illness through contaminated food products. Historically, botulinum was responsible for outbreaks of sausage poisoning through contaminated ham products and acquired its name after Latin sausage. In the modern era, it's more often responsible for poisoning via ingestion of raw honey in canned food. In infants, infection most commonly occurs through inhalation of spores from contaminated soil or dust. Oh, however, a common route of exposure is the ingestion of spores in honey when a parent feeds it to a child. The infant GI flora is not sufficiently mature to prevent infection. Botulism presents with rapid, progressive, symmetric hypotonia, hyporeflexia that begins with cranial nerves manifesting as ptosis, sluggish pupils, and diminished gag reflex and descent to the lower extremity, also causing constipation, poor feeding, respiratory failure. Diagnosis is confirmed by identifying the botulinum toxin in the stool. Treatment requires hospitalization and administration of immune globulin as well as supportive care, which often includes mechanical ventilation. It is not B. Measurement of serum cholinesterase can be performed in suspected cases of rhinophosphate poisoning. Patients classically present with diarrhea, urination, meiosis, yes, mentions, bronchospasm, bradycardia, vomiting, lacrimation. It is not, oh, that's a different question. Okay. It is not, where was I again? They don't have it here. Oh, this one. Electromyograph on nerve and repetitive nerve stimulation study can be done to support the diagnosis of botulism, but the gold standard is stool toxin acid. The diagnosis is supported by a characteristic low amplitude response On repetitiveness simulation studies that improves with never mind. Next.
Okay. A 9-year-old girl is brought to the emergency department 30 minutes after being involved in a motor vehicle collision. There is an there is an open fracture of the tibial shaft, and the patient reports severe pain in the area surrounding the fracture. On examination, there is weakness of toe flexion. There is weakness of toe flexion and severe pain with passive extension of the toe. Severe pain with passive extension of the toe and plantar hyperesthesia. Which of the following is most likely diagnosis? Toe, great toe. Mm,
Ready?
yes.
Okay. So it's oh, did not see that one coming. Compartment syndrome. Compartment syndrome occurs when there is increased pressure in the intramuscular compartment that compromises circulation and neuromuscular and neurologic function. Compartment syndrome commonly occurs in the setting of trauma, including lumbar bone fractures, and symptoms include pain out of proportion to the injury, paresthesia, and pain with passive stretching of the muscles. Mm, okay. Late findings are pallor, hoarseness, paralysis. Diagnosis is confirmed after clinical suspicion by measuring compartment pressure. Increased compartment pressure or minimal difference between compartment pressure and perfusion blood pressure confirm the diagnosis. Patients with compartment syndrome are treated with emergency fasciotomy to decompress involved compartments. Delays may lead to poor outcome. It's not E. Transection of the tibial nerve may occur in the case of high impact trauma or during surgical procedures. Symptoms may differ depending on the level of injury. These patient symptoms, including pain out of proportion to the injury, are more suggestive of compartment syndrome. I don't understand why the pain is out of proportion. He broke his leg, so the pain is normal.
Okay. Next.
Okay.
An 18-year-old woman comes to the office to request genetic testing. She was adopted at birth, and her adoptive parents told that there was a strong mechanical connection. Their strong mechanical history of psychotic behavior and a non-movement disorder. The patient has she's planning to start a college in the fall and has been excellent student throughout his high school. Physical examination shows no abnormality. There is no evidence of abnormal movements. Mental status examination shows anxious mood. She reports hallucination. There is no evidence of delusion. After further counseling, the patient elects to proceed with genetic testing. Which of the following is most likely diagnosis?
Ready?
Wait 1 second.
Mm-hmm.
Okay, ready. Is it Wilson disease?
Oh, that's what you thought? Okay, I guess. Okay. Maybe you
What is
got
your
it.
thought?
I thought Huntington.
I don't
Yes.
think so. Okay, let's see.
Based on the reported maternal history of psychiatric and movement symptoms,
You are right. Oh,
these patients should be offered testing for Huntington. A Huntington hereditary progressive neurodegenerative disorder typically arising in the third and sixth decade of life, associated with atrophy of the caudate nuclei in the basal ganglia, which can be seen on MRI of the brain. The disease usually presents with insidious onset or um, psych, psychiatric and cognitive symptoms. Motor symptoms like chorea, hypotonia, dystonia, loss of voluntary typically appear later in the disease course. Hmm. Patients with Huntington typically die 10 to 40 years after disease onset. Chorea, a um, key Huntington symptom, can be initially experienced as restlessness. Treatment is symptomatic and can include tetrabenazine or tetrabenazine, which target chorea by depleting dopamine stores. Huntington is caused by expansion of CAG chromosome on chromosome 4, which occur when we know that. It is inherited in autosomal dominant pattern and also demonstrates anticipation. We know what it is. It's not B hepato Wilson disease is caused by impaired metabolism of copper and deposition in the liver and brain. Most patients will have some degree of liver disease at the time of diagnosis. Neurologic and side manifestation are broad and can mimic other neurologic disorders, especially the ones with movement related symptoms. However, patients with neurologic abnormalities will almost always have fracture rings. This, along with liver disease, can help distinguish Wilson from other disorders. Parkinson is also characterized by movement related cognitive and sight symptoms, while having a first degree relative with Parkinson increases the risk of developing. The majority of cases are idiopathic. Larger risk factor is advanced age. Men are more likely than women to have it. Genetic testing can estimate the risk, but likely to be lower. Yeah. Okay. Next.
okay. Can we stop for